All right. Let's see. Let's see who's here. Not anybody at all is wanting to hear me tonight. I know we have a couple people sick. So a couple people are out. But anyway, that's why it all goes to the recorder. And you guys have a chance to watch it later. I know there's been some issues with some people accidentally logging in and getting the wrong test. The dates were off. I think Rob and I've got that situated. If you accidentally took a chapter test because you thought it was the right one and it won't let you take another one, it should be fixed now, but you still have to come to me for that to get situated. Rob can unlock a bunch of them, but at the same time as I have them kind of locked down so I can keep track of who's doing what, and I know basically I can keep a track on you guys, so we know that everybody's able to stay on the same page and all that fun stuff. So that's the reason why I have them locked the way that they are. Since I was wrong, y'all are going to learn about some cardiology tonight, but tonight we're going to learn about some respiratory. We'll go over cardiology on another night. So just remember, Tuesday is a travel day for me, so it'll be really, really busy. Please bear with me. So as I get ready to travel back to work, and I'll be talking to you guys as I'm back out on the rig. But Tuesdays, like every Tuesday going home or coming to work, is pretty rough for me. All right, so let's just go. And so we know here's all our components. We can't get away from these. These are some of the things that they make us tell you as you're going through class. You got to learn all your fundamentals and your standard competencies, so they get boring. Why doesn't that ever work? All right, so your respiratory. So what we're going to go over is your upper and your lower, which we've talked about this in the past, so you kind of have an idea. But we're going to dive also to starting to get a little bit deeper and a little bit harder.
What?
So what? Hello.
What rig do you work?
I work on the Holstein.
Okay.
DC 645. You can look it up. So we're going to dive off into the upper airway. What to recognize, what certain signs that you see is, and where is it located? So you'll have an idea of like, where are these? How do you do signs and symptoms for them? So my screen just decided to do its own little thing here. So you'll have to excuse me. I had to move it around. All right. So respiratory, anatomy, physiology, patho, assessment, and management. We're going to talk about epileptitis, spontaneous pneumothorax. How do we treat that? Pulmonary edema. What can you do to help treat that? Asthma and COPD. Chronic obstruction pulmonary disease is your COPD. You'll hear that a lot as we go through here. Some of your other assessments are going to be on environmental industrial exposures. What can we, and think about, it's kind of hard to teach y'all broadly about that, but look at your areas that you potentially plan on going to work. What is on your facility if you work on, like myself, I have anytime that we do a drilling and there's different types of muds or hydrochloric acid out there, we have to bring certain types of antidotes. We're getting SDSs, which is your safety data sheets. We get those brought to us, so we know, so we can have an idea. We know about a week out what's coming on. So if you're working at a facility, know your equipment, know what's in there, what is harmful, what is going to be harmful to others, and also in your area, know if you have these big, like a paper plant or a water treatment facility, some of these big things in your area. It's very good practice to know your backyard. So know what's going on. Toxic gases, what type of toxic gases? Peritis, cystic fibrosis, and pulmonary embolism, which you also hear me say PE throughout the night. It's a habit. We're talking about pneumonia, which is obviously it's really big right now because of COVID. That's where we're having some issues in the respiratory issues is with COVID, is in the pneumonia phase that is getting the people and it's setting in and it's not able to go away. And then your viral respiratory infections. Well, you can't have that. It's the flu season. No, it's not the flu. It's always COVID. All right. So patients often complain of dyspnea, which is shortness of breath, 1 to 2 words. They may have trouble speaking. They just can't catch their breath no matter what they're doing. They're just always out of breath. I can't breathe. Can be caused by many different conditions, and it can be difficult to determine. Dyspnea can be difficult to determine because that may be just their normalcy, how they talk, how they breathe. They may be obese, and that may be some issues. And now, is that because they are short of breath, or is that because they're having true symptoms of true respiratory issues? Even without a definitive diagnosis, you still may be able to save these patients' lives. And it's simple. The easy thing to do is we're going to apply oxygen. That's what we're going to do, and we're going to roll with it. Okay, so when you realize that and recognize it, that's it. We need that for early signs of transportation. All right. So respiratory system includes all the structures that contribute to breathing. So we talked about the diaphragm. We know where that's at. That is in kind of the diaphragm flexes and contracts. That's how we breathe. That's how we do our inspirations and expirations. The chest wall muscles, what do they do? Oh, I'm sorry. I already started yawning early. So what do the chest muscles do? So they hold the tightness in the chest, and it doesn't allows the lungs to breathe in a system, in a pattern. Accessory muscles. So when you start to have trouble breathing and you see somebody that's in a tripod position and you note that they're just not breathing normal, that's a respiratory issue, because now that their body is in this tripod position, it's very recognizable. So what you want to look for is when you go in the room, is this patient is literally in a triangle position. So their position is legs on the ground or in a chair, and they're just bent over. And basically, like I said, again, it's in a triangle position, that they're trying to take the pressure from their chest, the tightness and all that, and they're trying to make it and just hangs for gravity so they can breathe. And then the nerves to the muscles. So nerves from the brain and spinal cord to those muscles. Sorry, I got off on that tantrum about that, but I hope that just a little bit of explanation kind of helps you guys as we go through here. All right. So the upper airway consists of this. We talked about this when we were just dabbing off into the respiratory part, but we should know that the upper respiratory, because I'm pretty sure you'll see this as a question, contains the nose and mouth, jaw, oral cavity, pharynx, and larynx. And I want y'all to know what these are. So look right here. So here's your upper airway. So your pharynx, the back of the nose, coming down into the throat. Obviously, I hope everybody at this point in our lives know where the mouth is. And then your epiglottitis, and then your larynx. So that's your voice box, okay? So we know that, and that's, know the anatomy of the body. If you move on in your career and you decide to go to paramedic school, you'll have to have A&P 1 and 2, and you should, knowing the basis of the body is going to help you out in that part. Give a good idea. So then you see down in the bottom part of the bottom right of the picture, it talks about the lower airway. Has your trachea, your bronchioles, your main bronchi. Those are important because you need to know when you start having these COPD patients and the shortness of breath, depending upon are they getting good saturations, because maybe that their alveoli or their capillaries are just not oxygenating right. Okay, so if you listen to them and it sounds like they're breathing through water, they got fluid on them. Well, there's not anything as a basic level that you can do to get rid of the fluid off of them, but recognizing that in earliness can be a good thing. You recognize that super early and you can move on. Principal functions of lungs, respiration. Well, like I told y'all before, y'all know I'm addicted to I'm addicted to breathing. It is amazing. The exchange of oxygen and carbon dioxide is respiration. Air travels through the trachea and into the lungs, and then to the bronchioles, and the alveoli. So I'm gonna knock on the table on that one. Y'all probably gonna want to know that too. So if you'll notice, it talks about the bronchi, that is the larger airway, and then it breaks it down to even smaller bronchioles, and the alveolar is where the actual exchange place takes place. Because I need to know, where is oxygen carbon dioxide going to be exchanged at? That's important. Okay, so we're going to dive off and figure out, am I oxygenating them correctly? Now, am I blowing? Let's say if I choose a non-rebreather for somebody that's having shortness of breath, little, and I put them on 15 liters of O2, it may not be sufficient, because you're flooding them with oxygen. I like to start small and work big, and the reason why I say that is I like to start them out on a nasal cannula at about 6 liters a minute. If they can handle that, or they realize, this is just not working, it's easier to upgrade them than it is to downgrade them, because initially, when you've got their trust and everything, because you've given them the small and then you go big, then you're like, okay, well, maybe instead of trying to go big to small because you didn't really know what you were doing, it's okay. But that's just personal. That's what Chris Bally likes to do. So the pathophysiology of respiration. So we need to know what the respiratory process is. And there's two processes that occurs during respiration. That is inspiration and expiration. So breathing in, breathing out. Oxygen is provided to the blood and carbon dioxide is removed from it. In healthy lungs, this exchange of gas takes place rapidly at the level of the alveoli. Okay, so it's a faster process than really what we can think about, because we're like, okay, so if I take a deep breath, how long does it take to do the exchange and then turn around and breathe carbon dioxide? That's like, it blows my mind to wrap my head around how that works. I like knowing things and I like understanding, but then it's like, well, how long does it take? Like, I want to know. Like, just tell me. Well, sometimes you just don't know it that way. You just got to figure it out, because over time it blows your mind thinking about, how, okay, this is gonna go fast. Well, no, it happens pretty rapidly. So the inspiration and expirations are pretty rapid, of doing the carbon dioxide swap. All right, come on, computer. All right, so here's some of your charts on the patho of respiration. I'm gonna let y'all read that real quick. I'm gonna get a drink of water. So what it wants you to do is you see how it comes in and out. The blue is the deoxygenated, and then the red is the oxygenated, and that's where the changed. Maybe did I read that right? The one, deoxygenated blood is carried to the heart from the lungs by the pulmonary arteries and the arterioles. Gas exchange takes place in the capillaries covering the alveoli. Oxygenated blood is carried from the lungs to the heart by the pulmonary veins. All right, so it's letting you see the process right there on the far left-hand side, and it breaks it down into a smaller level where it starts to, carbon dioxide comes out, oxygen goes in, and that's the exchange process. So in the alveoli, oxygen passes freely through these tiny passages in the alveolar wall to these capillaries through the process of diffusion. It's the same thing if you think about, like, you're going to diffuse tea into a water. So that's just the way that I can easily think about it. That's the parts of diffusion. It is then carried to the heart, which pumps through the oxygen throughout the body. All right, carbon dioxide returns to the lungs and is exhaled out of the body. The brainstem senses the level of carbon dioxide in the arterial blood If the level of CO2 drops too low, the person automatically breathes at a slower rate. If the level of carbon dioxide rises above normal, the person breathes more rapidly. So that's where you may get your, and then you realize you're like, wow, they're kind of breathing a little slow. Well, maybe that because that's the brainstem itself is realizing, hey, I can slow down. I don't have to do so much. I can decrease my workload. Because when you sleep, your respiratory rate decreases just because the use and the force of drive that is needed is reduced. You don't have to worry about becoming short of breath or hyperventilating because your body realizes, okay, energy I can divert from this to there. It does it automatically and poof again. And that's how we get our good night's sleep. Oxygen exchange can be hindered by normal or pathophysiologic conditions in the anatomy of the airway. So that is conditions. There could be a obstruction. There could be some type of disease that affects there. We do talk about the disease process. You may have a traumatic where the windpipe may be crushed or they required to be intubated. Abnormalities in the pulmonary vessels. So those are huge issues that we start to have when we talk about oxygen exchange. Well, it's not the body's fault, but there's something that's causing issues there. So what we want you to do is recognize the signs and symptoms of inadequate breathing and know what to do about it. All right. So what we're gonna do? Carbon dioxide retention and hypoxic drive is the patient will sometimes have an elevated level of carbon dioxide in their arterial blood. Now, how are we gonna know that? I mean, I'm not drawing blood levels out in the field because I can't spin that. I don't know. But if the levels remain elevated for a period of years, the respiratory center in the brain may not function correctly. So that should be obtained and noted. The brain gradually accommodates high levels of carbon dioxide and then uses a backup system to control breathing based on levels of oxygen known as hypoxic drive. Use caution when administering oxygen to these patients. So if they tell you that they just hold high levels of CO2, it's going to be very hard for you to oxygenate this patient. So if you're like, oh my God, their sats are so low, we're going to have to build them up. Well, you're not. Even with CPAP, they probably live on CPAP. But what we're going to do in the ambulance, we're just going to treat their symptoms. We're going to make sure that they're okay. We're going to try our best to take care of them and that nothing else is going to happen to them while they're in our care. All right. So let's move on to the next one. All I want you to do is just oxygenate them, but be careful when doing that. And you recognize, or they tell you that something it's a repetitive issue that they know that they have. Causes of dyspnea. All right, patients often have dyspnea or hypoxia with altered mental status may be a sign that the brain is hypoxic. A patient often has difficulty breathing or hypoxia with the following issues: pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental and industrial stress. We just talked about that. Why am I reading that over? All right, be aware that one or more of the following situations may exist in the dyspnea patient. So the gas exchange between the alveoli and pulmonary circulation is obstructed by the fluid in the lung, could be by infections or a collapsed alveoli. Once they collapse, there ain't nothing we can do. Now, again, we're not going to know that, but that has to go to a pulmonologist. But just know there ain't no fixing that. If they tell you that they have, multiple collapsed alveoli, they're seeing a pulmonologist, you'd be like, okay, all right. So you want some oxygen? Because at some point they're gonna start telling you stuff. You're just like, I don't know what you're saying, Willis. I don't know. So the air passages are obstructed by muscle spasms, mucus, a weakened floppy airway walls. Blood flow to the lungs is obstructed by blood clots. The pleural space is filled with air or excess fluid, so the lungs cannot expand properly. So what I mean by that is you have a hemothorax or a pneumothorax. That is fluid or air in the pleural space. So obstructed blood flow to the lungs may be by a blood clot. That is something that it's scary, because if you go to intubate them and you're not careful, and it is right there on the trees, the main right and left main stem, you potentially could rupture that, and then you're going to drown your patient in their own blood. So you have to be very careful for that. We talked about damaging the alveoli. There's nothing, I don't know what to do. I can't fix it. That takes over time. But we're going to take our patient and we're going to treat them the best that we know how to, and give them supplemental oxygen to help their physical state at the time. All right. So here's you a chart on 16-2 in your book that talks about signs and symptoms of inadequate breathing. I'm going to let you read that again. I'm going to take a deep breath and drink some water. All right, so after seeing that, you've probably already seen these signs and symptoms. You probably just didn't know what they were, or you've known somebody that suffers from that. So it says the patient is coughing excessively. That can obviously cause shortness of breath because they can't catch their breath. Just, I don't know why I keep going. Obviously, my oxygen levels are low. So their breathing rhythm is irregular. So again, like I said, you've probably seen these. You just didn't know that those were signs of shortness of breath. But now that you know, now you have signs, abilities to say, hey, look, we need to treat that. We need to look out and see what we can do for this. Causes of dyspnea. Patients may also complain of chest tightness and air hunger? I've never heard of that term, but I'm just going to say they shortness of breath. Congestive heart failure causes the heart to pump inefficiently and deprives the body of oxygen. So anytime that you know that somebody has a COPD or they have CHF, always give them oxygen. They're probably already on home oxygen, but so let's talk about home oxygen. Why I talk about that. So in this case, you know that your patient is on home oxygen, okay? So we already know that they're going to be on probably about 50 feet of hose at probably 3 liters a minute. So if anybody knows a lot about pressure and size of hose and friction loss for any of my firemen in here, there's not going to be a whole lot of friction loss because it is a smooth plastic, but think about how far that oxygen is going at 50 feet at 3 liters a minute. How much do y'all think that patient is really getting 3 liters of oxygen? Do you think they're getting a consecutive 3 liters, or is it probably like 1 to 2 by the time it gets to them? What y'all think?
Like 1 to 2 by the time it gets to them.
But, and and I laugh because these patients are like, oh my God, I can't live without it. You take me off of it, I'm gonna start having trouble breathing. Well, I ain't even taking you off of it yet, but you're already making it sound like you're about to die. So what I like to do is I will take their O2 stats with them while they're in the home and on that oxygen. And I tell them, hey, listen, I have to get an O2 stat with you off of this. So as we go out to the ambulance, I'm going to be looking at your O2. Literally, out of all these times and years that I've done that, I think I've seen it drop maybe 2%. But yes, that is a lot. So please don't make me think that that's, so you could go in 2%, dropping from 90 to 88. That's a lot when we're talking about respiratory. But they really don't. I mean, you can literally put that nasal cannula back on them when you get in the truck, and sometimes I haven't turned it on, and then they're like, "Whew, I feel so much better." Well, it's a mental thing. It's like the guys and gals that go from smoking or dipping or chewing to stopping. It's a mind habit that they got to have something in their hand or take a deep breath or spit or anything after they eat. They get used to it. Tamara says they get used to it, and it becomes a mind over matter situation. Yes, and then not talking about your mother, Tamara. I'm sorry, but it is a very thing. They're used to that noise, and they're used to it in their face because, oh my God, it's helped me out so much. No, it hasn't. No, it hasn't. So be cautious of that. Even though you see people with those on, just know that they're going to give you those, oh, I can't breathe. I'm having so much trouble. Okay, all right. I'm watching you. I got you on the monitor. We're going to take good care of you. So it at that point, it is an addiction. And then there are some that literally can't live without being on it because of their O2 stats are so low. I've seen both. So I'm not telling you don't put every single patient on, oxygen as you go out to the truck, because that's neglect. But at the same time, is treat your patient, not your monitor. If the patient appears to be okay and they're not complaining anything, that's okay. If the monitor says that they look like a bag of ass, and you're just like, oh God, I got to do something, but the patient doesn't have any complaints, it's okay. You can move forward. You can rock on with that. All right. So back off my my high horse there. So severe pain can cause a patient to experience rapid, shallow breathing without the presence of a pulmonary dysfunction. So if you turn around and shoot somebody, shoot them in the leg, the pain sensory is going to increase their respiratory drive. So their respiratory rate is going to be increased, but it's because this the pain sensation. So if you give somebody like myself, if I give somebody morphine's going to slow you down. So you should expect their respiratory rate to also slow down, but you want to be able to supply them oxygen because you know in your head that that is caused by pain sensory. Well, again, that I guarantee you, whatever company you go to, it's going to require you IVO2 monitor on trauma patients at a minimum. That is for the paramedic level. For a basic truck, I can't promise you what it's going to be, but I can almost say that it's going to be consider C-spine precautions and oxygen. At the minimum, that's what it's going to go for. Sorry, I was answering my wife. She's not here. She had to take my daughter to cheer. So, but so just know that you're probably going to have to provide the oxygen early, because when you get in these traumatic situations, you know that that's going to be an issue, and then you're like, oh my God, are they having trouble breathing? Well, no, it's because of the pain sensory that's creating that. All right. So let's dive off into your upper and lower airway infections. So infectious disease caused by dyspnea may affect all parts of the airway. So oxygenation is a problem of inadequate oxygen delivery to the tissues. So it's not going all the way down to the capillaries. The problem causing dyspnea is always some form of obstruction. Can be mucus, secretions, an obstruction airway in major passages could be cold, diphtheria, swelling of soft tissues in upper airway is like epiglottis, croup, and then you have an impaired exchange of gases in the alveoli is called pneumonia. Be very, very diligent about the use of proper PPE when contact with a patient who has infectious disease. So know that it's okay to put these patients on mask if they're not complaining of a respiratory, if they're not complaining of a respiratory complaint. If you know you go in there and this patient has pneumonia or the croup or the cold or whatever, I mean, obviously right now is the time that everybody wears masks, so it's okay for you to reach over and give this patient a surgical mask or a KN95. That's okay, because the way that you look at it is I'm trying to protect the sick patient from what I have, and I don't want what this sick patient has. So again, I always like to say, hey, for your safety, I would like to put you on some oxygen. Put you on a mask. Because right now with this state that you're getting sicker, I don't want you to potentially pick up anything from me. So that's why that's the easiest way to get out of things when they start to complain about having to wear a mask in the ambulance. All right, so inflammation and swelling of the pharynx, larynx, and trachea is typically seen in children between 6 months and 3 years of age. So that is the croup. Some of your true signs of this is going to be the stridor and the seal bark cough. Croup often responds well to administered of humidified oxygen. So y'all know you hear this oh when they start coughing, because that is the croup. So the way I like to look at it is croup and virus have the same letters. There's 5 letters for croup, 5 letters for virus, because that is a virus. Epileptitis is not, you start talking about, here's epileptitis. That is a inflammation, and that's going to be more noted to have to be required by antibiotics. So to figure out the difference between croup and epileptitis, if you hear that seal bark coughing, you know that's a viral infection. Okay, so then you move over to epileptitis. That is an inflammation of the epileptitis, usually as a result of a bacterial infection. So you notice that infection, I always like to say, is it a big word or a little word? So it's infections and epileptitis are partners, virus and croup. So more predominant in children, but can occur in adults. That's not unknown. Is that the same as strep? No, it is not. Because anybody can get strep. Especially if you don't have your tonsils. I'm very, very prone to getting strep. I still have my tonsils. I've never had chicken pox. I've never had that fun stuff. But if I know that somebody has strep, I'm like, oh, don't breathe at me. Don't look at me, because I get it regularly. So here's a little telltale. If you'll look on your second bullet, that's very important. Some of the signs that are often found that you can see with a child with epileptitis is they're going to be in a tripod position because they can't breathe, and they're drooling because it hurts to swallow. So you want to provide them comfort. I love to write in my report, comfort care was provided, high flow oxygen, and do not put anything in their mouth. You don't want them to have a sip of water. You don't want to suck on one of those little lollipops. If anybody's in the military, you all understand the little lollipops. It helps keep from the sore throats, or keep your throat from, they handed up, there's a little lidocaine lollipops like they were candy. All right, so respiratory, RSV. We're seeing a lot of RSV come around again in our children right now, probably more in your toddler range. I would say probably from your 4 and under for your RSV. That is a very common illness in young children. It causes an infection in the lungs and the breathing passages and leads to bronchiolitis and pneumonia. So if it's not treated early, or the parent says, oh, okay, well, let me just treat you some over-the-counter meds. And I'm the same way. I'm a very adamant of over-the-counter meds. I don't like to fill up the local doctor's office for my child when there's something that I can treat them with. But at the same time, as I'm not retarded about it to where I don't want to try to keep my child home and cause more harm out of it. So if they need to go, they need to go. At the same time as I'm not opposed to starting an IV on my own child and be like, I told you I was gonna get you. Now, RSV is very highly contagious. So you have to make sure that you wash your hands and make sure that if there's anything that they touched or they may have drooled on or spit on, that is cleaned because they're going to get that that can spread. Assess for signs of dehydration. You can do the pinch test. If nobody knows what I'm talking about, lay your hand flat in front of you, pinch the top part of your skin, pull it up a little bit, and you can turn around and see if you're dehydrated because your hands stay in a like a pinch sphere, like the skin stays kind of pulled up, and that's a telltale sign if you're dehydrated or not. So that's the biggest issues there. Reginald, I see your message and give me a second. So some of the symptoms of RSV, you're gonna look for a runny nose, COVID-like symptom. So I'm just gonna knock this. A decrease in appetite, cough, sneezing, fever, and wheezing. So they don't really have that bark when they have the croup versus the RSV or the hepatitis. But you really won't see drooling in this. But just know that if they sneeze, it can be done off of that too. They can contagious to somebody else. Right there on y'all's screen, it shows humidified oxygen is very helpful because it just adds a little bit of moisture to the air. RSV right now, let's see, so there's different types of stages of RSV. The early phase of RSV in babies and young children is often mild, like a cold. In children younger than 3, the illness may move into the lung and cause coughing and wheezing. In some children, the infection turns to a severe respiratory disease. My middle child at 4 months old contracted RSV and it hit fast, falling in the chest and abdomen. So these babies can get super, super sick. I mean, and depends on, you may see it more predominant, depends on what part of the country you're from. I know that I know several kids that's had RSV here recently, but I mean, it's still 9 million degrees outside with a humidity of 140,000%. So, I mean, some areas I know are starting to see into the 70s. I'm really jealous. I don't like you kind of people. You'll have that temperature, just don't tell me because like you get out the shower down here and you're still sweating. You're like, you can dry the water off, but it's sweat, not water. So just think about that depending on your area. As you start to notice the weather starts changing outside, the humidity changes, the seasons change, you're going to get these calls more. And I'm going to tell you, and I fully believe it. I've seen it for 20 plus years. I will say it right now in front of y'all. We'll take a bet when it gets going. But just know, COVID is a viral infection. So viral infections don't normally spread as fast as COVID is during the summer months. So more likely they're going to spread during the winter and cold months. So that's a problem. I'm not telling y'all to, rush and get vaccinated. I'm not telling you to go empty the shells, but depending upon where you are, you may see another uptick in COVID because of the temperature change. It depends on how fast whatever of COVID is met, that you may see this rise faster than some other regions. And then you'll hear this. I thought it was funny today that there was a country that went on complete 100% lockdown because of one COVID case. So 20 plus years, hey, don't laugh at me. I know what you do when you're poking fun. All right, so bronchiolitis. So here's the thing. So some of these are, it's a viral illness that occurs due to RSV and it usually affects newborn and toddlers. So that is the good thing about getting old, is not really many of those bother you anymore, but then you just have death that's closer. That's something I got to look forward to. So bronchioles become inflamed, they swell, and they fill with mucus. So this is where you can get your younger ones that are coughing up mucus, and you're like, wow, like that's like a deep cough. But when you provide like oxygen therapy to these kids, it does help them, and you will notice that their breathing gets a little bit easier. Their workload is not as much. So giving them an early, I mean, I like giving out kids oxygen way faster than I do an adult, because the way I like to look at it is kids are going to compensate way faster than adults will. So that being said, is I like dealing with kids, but because kids can't tell you what's wrong, you just got to figure it out. But if you don't figure out fast enough, they'll bite you in the butt, because you can't do it fast. You can't go fast enough once it bites you to fix the kid. So you got to jump on that early. Let's talk about pneumonia. I'm sure some of you folks have know about pneumonia way more than I've never had it, knock on wood. But pneumonia is something that's serious. We got to take that with caution, especially right now. You see people getting pneumonia, and it is 147 degrees outside. So that's nerve-wracking. We had a little young lady in our area just yesterday. I think she was 20s, in her early 20s. She was having blood pressure problems. They couldn't get her blood pressure up, but they couldn't sedate her to try to fix it, because we have no ventilators in our state because of people with COVID and pneumonia and all that. So this young female died because we don't have no ventilators. So it's sad. But pneumonia. So the general term that refers to an infection in the lung. If you can, or if you want, you care, Google the difference, a normal lung, healthy lung, a COVID lung, and a pneumonia lung, and you can see the whiteness in the lung, and that is just the muck that's in there. Sometimes it's often a secondary infection that begins after an upper respiratory tract infection. So that's the reason why I really don't like to, if I deal with somebody offshore that comes to me and it's an upper respiratory infection, or URI, I really don't play around, because if it gets down into their lungs and it sits and it makes that dark, nasty, greenish mucus, that's not a good thing. They're sick. You're going to turn someone into being worse off if you would have just jumped on it to begin with. Bacterial pneumonia will come on quickly as a result of high fevers. So it's very important to stay on that medication regimen of every 6 hours. You can split it up every, between your Tylenol and Motrin. Those are very, very, very good. I'm not trying to be a parent, or especially at all, what you should or shouldn't do. But just know that the high fever is going to drastically go against the child and their self. Vowel pneumonia presents more gradually and less severe. Pneumonia especially affects people who are chronically and terminally ill. We've seen that in some of your long-term facilities. You see that because pneumonia will run rampant through a long-term facility, because it just goes room to room to room to room. And then some of your like hospice cares, you'll see that it's not so much in a hospital, because of the hygiene is better off. You have a lot of your nurses that will wash their hands, clean their hands, put gloves on. So you don't get that. And I'm not saying that doesn't happen in a long-term facility of a nursing home or a hospice facility. It's just more common because they're going from sick person to sick person to sick person, and they don't want to transfer that around. You always want to assess the temperature and determine presence of fever of any child that has pneumonia, because their fever can spike super, super fast. Provide airway support and supplemental oxygen at the minimum. Don't do anything less than adding them support. Let's see, bursitis. Do y'all have any questions? I've tried to answer y'all's questions as we keep going through here. I know we should be coming on a break in a few minutes, or about 15 minutes. I just want to double check with y'all. Everybody good so far?
I have a question.
No way.
I have a question.
What's up, love? What you got?
So, I know when you were saying earlier, and it wasn't on the slides per se, but so whenever, how did you word it? It was like they have lower carbon dioxide outtake, then they're gonna breathe more rapidly.
So
Is that
when you're talking about when the brain and the spinal stem realizes that the CO2 is too low.
yeah.
So that's just so what I'm trying to get to is that the body will recognize that the CO2 levels. So that if the body sees that the CO2 level is too high, you know, when you're sitting there and you just take that deep breath every now and then, or when
Yeah.
you go to, like, obviously when I'm trying to talk to you guys and I yawn, it's my oxygen levels are too low because I'm talking too fast, or I don't stop and take deep breaths. That's really why I yawn, not just because I'm bored of talking to y'all. It's just my body realizes he's low of oxygen. We need to get him. So you'll even be sitting there and you're just like, and you're like, what caused that? That's why. Recognizing that and understanding, if you're interviewing a patient and you see that, you may understand, be like, hey, I tell you what, let me give you a little bit of oxygen. Let's see if that helps you out. Well, how'd you know I was having trouble breathing? It would have been nice for you to tell me that when I asked you what'd you call me for. You know, so seeing those signs of carbon dioxide issues, or notice the respiratory rate's a little low or super fast, may tell you some hidden signs that the patient is just not telling you about. Thank
Okay.
you. Anybody else got any questions? Y'all all quiet? Reginald, you actually, one time, I know you got something to say. You must be working. All right. So good. All right. So going over, let's say bursitis. That is a airborne bacterial infection that mostly affects children that are maybe around six-ish, youngest. I'm trying to answer my wife on something, y'all. I'm sorry. So patients with feverish and exhibit a whoop when they sound on inspiration. When you listen to their breathing, make sure that you have the right size bell on your stethoscope. If you like single bells versus dual bells, it depends on what you choose. That's a personal preference. I like dual bells where you rotate it. You got the big cup, little cup. Make sure you listen to them on the right side. So what that does is it just helps you when you do your assessment. But listen for that. You'll hear it. It's kind of, if you'll Google that, it's actually easier. You can Google that respiratory sound. It's really neat how they've got those over time and they talk you through it. There's actually a pretty neat little YouTube channel that shows you the respiratories, and he talks in depth about it. I wish I knew it. I've seen all these and I don't ever write anything down. Highly contagious. Whoo, this bursitis is contagious. And it's passed through droplet infections. Again, you should be wearing a mask, especially this time and age. At this point in our lives, everybody's going through a new pandemic. We don't know what that is, but we're all going to live with it together. Watch for signs of dehydration, because children will compensate fast. If they start seeing signs of dehydration, you need to encourage ALS intervention. You need to ask for a unit to get close so you can help with the hydration. If they start to have trouble swallowing, you may have to suction. And it's one of those, it's just something you can turn it on, teach the kid how to do it, and they can do it themselves, or mom or father that rides with them, that they can suction them, because the parent needs to be included in the care, so the parent's not just taken out of the place. Because I can guarantee you try to separate a 6-year-old child from one of their parents when they're super sick, ain't gonna happen unless that baby is super sick, or there's a child abuse issue that may have gone on. They don't want to be around them. So there's also another sign for you to be able to look out to, is if that kid comes to you and is looking for help versus clinging to a parent because they're sick. So that could be some other signs that you can look for, especially when that child is sick. Oh, let's see. Oh, come on. All right, so this is the flu type A and B. We're talking about influenza A. B is not in here, but so does anybody know how we base our flu seasons off of? Where does the CDC get their guidance on how we base our flu seasons off of? Does anybody know that? Ooh, I'll tell you. All right, since y'all are quiet, imagine that. I'll tell you what's going on. So every year, the CDC bases off all of their potential recommendations off of what is happening in Australia. Well, last year, we really didn't have a flu season. Australia had a major lockdown, and they didn't have a flu season this year. So we don't have any data to go off of. There is no information for us to build flu vaccines next year. So I personally am pretty interested to see what flu vaccines they're going to come out with because they don't have any data for it. But that's just my little tidbit. So I taught y'all something y'all may not have known. Hope I'm actually teaching y'all a lot of what y'all don't know. So y'all know what flu season, what all the sorry, I'm fussing at my child. He's eating junk as food's coming. A fruit roll-up's not junk. I'll have 20 people in here can guarantee they can tell you yes it is. All right, so the biggest thing is what we want you to do is during the flu season, as y'all know, is be careful on dehydration and pneumonia, because if it goes untreated for a while, that's what it can go into. And oh, look, they said it was fruit, but it is not fruit. Hey, go learn something. All right, the slide y'all been waiting on this entire time. COVID, imagine that. So SARS-CoV has always been around. It's always been around. That's what's going on. The 19 comes from is because that's when it was found. That is the year that it was found as COVID-19, not because of that's just I don't know what to tell you, but that's just the year. All right, so it is transmitted through aerosol drops, through airborne particulates, generalized by sneezing or coughing in direct contact. So what I try not to get into personal issues here. I'm teaching y'all Chris Wally's way versus personal thoughts and medical wise. But what confuses me and how to tell y'all is because they change stuff so much about this is because we still don't know. I've seen here recently that you can be 3 feet from somebody instead of the 6 feet initially. Then I've seen 6 feet. I see the vaccinated versus unvaccinated, the higher the contamination rate of being diagnosed. I don't know what to tell y'all because it just depends on what y'all read. I've read 2 studies from the same place that they contradict themselves because they're learning more about it, so now they can go back and say this. Well, that doesn't help me. I don't know what to tell y'all. Just be careful. I just want y'all to be safe. I want y'all to have whatever decision you make as an individual. There is actually 11 of y'all in here. So I want the 11 of you to make the most educated, best decision that you can for you, your family, and your health if you decide to get vaccinated or not. I don't really care. That is a complete different total topic. I just educate y'all to be, I just want y'all to be educated on the decision you make.
I had a question about the COVID. If you know, maybe.
I'll try. What's up?
My daughter-in-law is pregnant and has COVID. She has a 1-year-old and her husband. and neither one of them have it. And they were
Okay.
all around each other together. How is that when it's supposed to be like spread in close quarters and by the aerosol droplets and airborne, all that? How is it possible for them not to get it? Is it because maybe their immune system's different because she's pregnant, possibly?
Well, so let's talk about the pregnancy first. I do know that just because she has COVID does not mean that the baby will come out with COVID. Now, it is very highly recommended that they breastfeed because they will get some of the antibodies. So, not in nobody's business. I don't care what she decides to do. It is highly encouraged that they do get the mother's milk because it's really really well.
She is
Um,
gonna breastfeed, but
so it's a good thing. Now, staying on the other two. So my wife and I had it in December, the first week of December. Both of us were super super sick. We didn't go nowhere. We stayed at home. My three kids, we have hers, mine, and ours. All three of them stayed in the house. The three of them did not get it. Uh, I still carry antibodies from them. Matter of fact, my wife and I are going to go check again before I go back to work to see what the status of our antibodies are. But it is known that they may not get it. See, Rebecca says, my husband and I both had COVID. I breastfed my baby and she was 1 year old and stayed in the house with us the whole time. The baby never got COVID. We were all tested multiple times. I hate to say it, I despise it. I don't know your answer because I hate saying I don't know. But the best thing I can do is tell you to ask questions and educate yourself better. And if you find out a better answer, please come back and let us know. I think there's not enough out there about COVID for us to understand, even though COVID has been around freaking forever. They get it in animals. COVID, like the SARS part, is always in animals. We know that. Cows get it. We've seen it. I mean, like anthrax, it's there. I don't know. I mean, it's common. I hate to say it that way, but it is something that is there. But when it's messed with and it's missed by, go ahead.
I was just wondering if maybe you had knew something more than what I've been hearing and things. And she says something about that because she was pregnant, she had to get extra shots while she was in the hospital.
I don't know that. My sister-in-law just had her baby like 5 weeks early because she went into the hospital with COVID. Literally, they told her, "Hey, you're going to be transferred to another facility." She gets there. "Hey, we're fixing to sedate you, put you on a ventilator, and deliver your baby. We'll see you in a couple hours." Boom. That's the conversation they had.
Wow.
Yeah. See, Rebecca says we vaccinated against corona in animals and have for years. I mean, it's been here. I don't have an answer for you, but the best I can tell you is it's like the flu. The more you're around it, the better your body builds against it. When I used to ride the ambulance almost full time, I probably worked more there than I did the firehouse. I never got sick. So it's like, I obviously know I don't want COVID again. Don't get me wrong, because the second time I had it twice. The second time was horrible, but I think that you do build I personally believe that you do build up some, resistance to it. Now, is it the same as getting it? I don't know. Now, I know a friend of mine has it right now, and he just got the antibody infusion done. They came to his house, kept him there, and did it. It was a 2-hour process. I mean, I know that they're delivering 2 types of medications in this infusion. That's the best I can tell you. I don't know anything other than that, Mr. Sorry.
Okay. I was just wondering because like when I went in labor with my son, I mean, and this was years and years ago. My baby's 23. But I had bronchitis when I went in labor with my son, and he was born with bronchitis. And like he had to be on the oxygen tent and all that when he was like 6 days old. And I just kind of wondered maybe if that was kind of in the same lines as that? Because like what the mom has, the babies have, you know.
I mean, it's a good point. I mean, I hate to say again, is we just don't know enough about this. But I can tell you, this is going to be around forever. Our grandkids are going to know about COVID because it's going to be around. It's a money making proper. It's a I don't know how to put this. It's a money making process for some particular people, and it won't go away. Same thing as cancer. It could go away, but it's not. So sorry to go down a rabbit hole. I hope it helped you out, Mr. Hammer. I hope there was a little bit of information that you got out of there.
Okay, thank you.
I show straight up an hour. Let's take 10 minutes, and I'll see you at 10 after. Anybody have any other questions? All right, see y'all in 10 minutes. All right, sorry about that, y'all. I had to take a phone call real quick. All right, so let's get off this wonderful thing we talk about COVID. Get rid of that. All right, so TB, so tuberculosis. That's a bacterial infection that most commonly affects the lungs. It can also be found in almost any other organ, not organ. Oh, come on. It can remain inactive for years, but before producing symptoms, patients often complain of fever, coughing, fatigue, night sweats, and weight loss. The prevalence is higher in homeless people, prison inmates, nursing home residents, persons who abuse IV drugs or alcohol, and those who have HIV. If you suspect a patient to have TB, you need to wear at a minimum gloves, eye, and an N95. I was exposed to a patient years ago with TB. Once we found out, we all had to get treated, and I was the only one out of the group that failed the TB skin test. So I had to take the x-ray. Didn't show anything. I've done it for years afterwards to make sure everything's clear, and had to take that nasty medicine for a long time. It's huge, just to let you know, but there is medication for that. Acute pulmonary edema. So that is where the left side of the heart cannot remove blood from the lung as fast as the right side delivers. There's a picture I'll kind of show y'all in a second. Fluids do build up with the alveoli and the lung tissues. It usually results from a congestive heart failure. Patients usually experience dyspnea with rapid, shallow respirations. In some severe cases, a frothy pink sputum forms at the nose and mouth. It's gross. It's noticeable. Most patients have a long-standing history of chronic congestive heart failure and kept under control with medications. Not all patients with pulmonary edema, though, have heart disease. So think about that. We look for the froth. Now, you have some people that just talk on a regular basis and they spit. That's not what I'm referring to, but it is it's a pink frothy. It makes sense, and you see it. To go back on TB, I will tell you this. If just call on me when I'm talking about the frothy. If a patient sneezes, coughs, or coughs up any looks like lung tissue, it is literally it's a pinkish color that is active TB. So that patient is very, very contagious. So go back here. So the frothy sputum is at the mouth and nose. I've never really seen it come out the nose. I have the mouth. It is kind of like, what is that? You don't want to be ugly to the patient, but you're like, ooh, that's gross. So I don't really know how else to tell them for that. All right, so here's pulmonary edema. So you see the fluids overload the alveoli right in here. So it's starting to get full. So they're going to complain of respiratory difficulty breathing, respiratory failure. Because see how these sacs are starting to get full with fluid. So then if you move over to, that's just one section of the sac that is filled. So you can imagine all these other sections are getting filled right in here because now the heart can't move it out as fast as they need to. So they're going to start to have trouble breathing. It's going to affect the exchange of O2 and removal of carbon dioxide. The patient will know that. That is something that they're going to know that they have acute pulmonary edema. So it's not something that you may, let me say that, you may rarely find that in the field and the patient not know, but you probably won't know what it is. You'll just know that the patient is in respiratory distress. That's more of the easier thing to say. COPD, this is a lung disease characterized by the chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. All right, so an umbrella term used for describe a few lung disease, including emphysema and chronic bronchiolitis. So with those, they're already said that they have COPD. They have emphysema and chronic bronchitis. Tobacco smoke, obviously we know a lot of people that smoke for years come down with COPD because what it does is it affects the ongoing of irritation of the trachea and bronchiole, and it also does start to clog those bronchi with tar, and it just makes it to where you can't hold oxygen in there. With bronchitis, excessive mucus is constantly produced, obstructing a small airway and alveoli. Don't mistake that with the smoker's cough. Most of the time, the smoker's cough is dry. It's not a wet producing cough. And I say most of the time. So airways are weakened and the protective cells in lung that remove foreign particles are destroyed. So the ability to get all the filtering out is gone. You can't do that no more. Chronic oxygenation problems can lead to right heart failure and fluid retentions. So COPD is bad. I mean, you can live with it, but you're going to continuously to live in a respiratory compromise. That's just the way that you're going to live your life. I smoked for a while. I smoked when I was overseas. It kind of took a lot of. It was just what you did to function. I don't smoke. I don't vape. I don't dip. I can't dip. Dip makes me the sickest I've ever been in my life. But it's not because I want to. It's because I know more about it now. And like Ms. Tamara says, her mother has COPD, emphysema, and CHF. You see these people, and they don't know. Some of them aren't just smokers. Sometimes they just get dealt a bad hand. And once you see these people live this way, it sets, kind of opens your eyes. You're like, no, cuz I don't want to be like that. So that being said, is just watch yourself. That's why I don't really mess with the lungs. I treat it aggressively. If I know the patient's sick, I'm gonna treat them with a high dose of antibiotics and try to move forward. That's my little bit of philosophy there to try to help. COPD is rough. So emphysema is the most common type of COPD. Emphysema is the loss of elastic material in the lungs as the result of chronic stretching of alveoli. Smoking can directly destroy the elasticity of the lung tissues, and most patients with COPD do have elements of both chronic bronchitis and emphysema. So here's your picture right here of the elasticity that is gone. You'll notice the inflammation of the alveoli results in obstruction. That's scarring some right in here. You'll see this is where it's trapped air, and it just ain't going nowhere. You see the obstruction right in here, the mucus that just lives there. This is what we want to see. I know sometimes we can't help it, and you may get, like I said, dealt the wrong hand, and this is what you live with. I've known people that lived their entire lives rolling their own cigarettes, smoking unfiltered, never once had a respiratory issue, but their family members died of COPD that never smoked a day in their life. So, and what did you say? If you don't have to be a smoker, absolutely, that's correct. So it's an eye opening once you get into this field. You're like, oh, okay, yeah, oh no, I'm not going to do that. I'm all right, thank you, appreciate the offer. I'll tell you, there's sometimes that I still, after really bad days, I'm just like, I just want to smoke, and it just makes me sick to smell it. I really don't. I just like to say it. Makes me feel better. Going more into COPD. So this is a wet virus versus dry lung. Patients with pulmonary edema caused most often by congestive heart failure will have a wet lung sound. So you'll hear more of the rhonchi and crackles when you auscultate the patient's lungs. And patients with COPD will often have a dry lung sound, and you'll hear the it's a wheeze when they breathe. That is, sometimes it's audible, that you can hear it without listening to them. And don't just assume that all COPD patients have wheezing and they have congestive heart failure. Patients do have some crackles when you listen to them, but make sure you always auscultate the lungs when you have a patient that it's in respiratory compromise. You always want to listen. Treat the patient, not the lung sounds. Again, treat your patient, not your monitor. If the patient is okay, that's fine, move forward. If they tell you, hey, I'm starting to have a little trouble breathing, be prepared. Have your stuff there. Don't be like, oh, well, you did it a minute ago. Why you got it now? Times change, bro. Complaints change. That's why you assess them so often. All right. So, asthma, hay fever, anaphylaxis. We know this already because we've dealt with this in our regular life. We know what these are. So dealing with asthma, the patient's going to know that they're either allergic to something. They do have an EpiPen to help them. So they may have their inhalers. I don't know why I said EpiPen. I have no idea, but I just said it. So asthma, hay fever, and anaphylaxis result from allergic reactions to an inhaled, ingested, or ingested substance. So for asthma, you can go for years. She's here. She's pulling up. So you may have it for years, and it just triggered by something else. But the same thing with yes, I see that, Tamara, because I am leaking oxygen. Maybe I need to go to sleep. Hey, and I don't know if y'all knew this. I just want to tell y'all that if y'all need my address, y'all, I need to pause the class for a second. I need to tell y'all something really important. For me, tomorrow is the most, oh, sorry, wrong one. The most important day out there. So tomorrow is my birthday. So if y'all want my address to send me any gifts, please let me know. I will take them. It doesn't matter if they're going to be late, but I will still take them. I'm not a fan. I'm not a flower friend, so don't send me no flowers. I do take cash, checking, and all major credit cards. So y'all just let me know what y'all gonna send.
Go ahead and send that address, Wally.
My son's sitting here looking at me like, they gonna send you something? I was like, no. All right. Where am I at? Let's see here. So, all right. So here's why we start to have this issue when we start breathing. So if you look at this chart, so this is your bronchiole. So you see how the mucus, this is the same thing that you have when you start to have like a clot, because it starts right in, oh, where'd my cursor go? So right here, the mucus is starting to obstruct the bronchiole. It's the same thing on your vein when you start to have like a JVD, which is jugular vein distension. This starts to swell. You notice there's no clear passage through here. So when you start to have cardiac issues or respiratory, any type of valve compromise, that's what we're referring to. I'm sitting here pointing at my screen like y'all can see it. Come on. So that's what we're referring to through this process, is that something is obstructing the valve. We just need to figure out what. Well, now you're starting to see that the valves here are starting to be obstructed by mucus. Oh, okay, but we can fix that, not in the field or not as an EMS, but we know when we do early recognizing that we can fix that. So Kobe, man, I appreciate that offer of me to take registry for you. I really do, but I'm gonna pass that one. I've taken it, and I'm not doing it again. I appreciate that, bro. I know. Don't shake your head at me. Don't shake your head. I appreciate it.
So wrong, man.
No love, no love. All right. So when we talk about the asthma, you see the asthma normally affects people from 5 to 17. That's on a normal stereotypical basis. Now, I know grown adults that have asthma that have their inhalers. So but that is the major age group that they factor in. Let's see here. An acute asthma attack may be caused by allergic reaction to specific foods or some other allergen. Attacks may be also caused by severe emotional distress, exercise, and respiratory infections. And in most severe forms, an allergic reaction can produce anaphylaxis. Now, that's the worst case, because you can't come back from anaphylaxis if not treated. If it's not recognized, I don't know how you will fix that. Because if the patient has their EpiPen and you realize that it's needed, but the patient is unconscious, well, guess what I'm gonna do? Chris Wiley gonna give him that medicine, but it doesn't say that I can do that. Well, you let your patient die. So which one would you rather do? I'm going to give it to them. I'm going to make sure that they're taken care of and the patient has the medication and stuff that they need. So early recognizing of this, using your diagnostic tools, your stethoscope, your pulse ox, your vitals, your reassessing, you doing a very good assessment is what's going to allow you to recognize that as early as possible. But I will tell you, probably the very first bullet, you would probably see that again. Affects all ages, but it's most prevalent in the ages of 5 to 17. That would probably be a good test question. All right, so hay fever is also allergic rhinitis. Its causes common like symptoms includes runny nose, sneezing, congestion, and sinus pressure. Symptoms are caused by an allergic reaction, usually to outdoor airborne allergens. Anaphylactic reactions are severe allergic reactions, and they are characterized by severe airway swelling and dilation of the blood vessels all over the body. So what does dilation mean? Can somebody tell me?
Opens it up, makes it bigger.
Okay, just want to make sure. I know y'all some smart individuals. I know it. I've had some classes be like, oh, what you talking about? So cool. So it makes it bigger. So we know that. So this may be associated with the widespread hives, itching, and signs of shock and symptoms similar to asthma. So with hives, they run the body. So it's moved through by blood. So that may indicate why that you get the hives all over. And you're starting to have this allergic reaction because everything's dilated. So just kind of give you all in the back of your mind what's going on. So the airway can swell so much that the obstruction is possible, that their airways can just close off. It's not saying that it will or that it's going to happen every time. But when
How do
you
you
start
think
to
I
have
swept
that
them off this floor? These floors while you were gone.
So when you have this,
Tell me, what do you
can
think I did?
actually, if the patient tells you that they
Yeah.
have this itch,
When you were gone yesterday.
they have this itch and that their throat starts itching or their throat starts swelling, know that that's a sign to say, oh God, I got to do something, because it's close to time that their airway is going to start closing. So that's the easy sign for them to tell you. So the only treatment that can be done is epinephrine is the treatment of choice. Oxygen and some antihistamines are helpful, but you need that epi. You need that release of epinephrine into the body. We can give it by IM is the best way, and that's the same thing that's intermuscular. Excuse me if it's just me. So through intermuscular, which is IM, which is into the leg, and you always want to go to a big part of the body, and that is into the leg. Some of y'all may have some 20-inch guns on your arms. I don't know, but give it in the thighs anytime you have to. Rebecca, you were correct. Anaphylaxis does suck. I have seen some patients that sit there, talk to me, and it's like, boom, done. I was not ready for them to go into anaphylaxis. I've had some pass away on me due to it. No matter what I did, it was not anything I could do. I had a guy literally swallow a bee. Didn't know he was allergic to it. Guess what? We found out on the way to the hospital. He woke up with a tube in his throat that I put there. So, I mean, it can happen to anybody at any point in time. Just be prepared and be ready for that. That it's a scary situation, but if you know these signs and symptoms early, it can help you out recognize and be like, you're not sucking for air as you're drowning at the end because you're like, I wasn't paying attention, I didn't make no notes, oh God, now they're in anaphylaxis. So just stay on top of knowing what your signs and symptoms are. And Rebecca's put in there epibenadryl steroids. They do help. That is something, all those do help. It's not a big deal. Sometimes some people carry those with them. Some people just don't know. You have to be careful about the Benadryl because they're going to want to go to sleep on you. But that's something that you need them to stay wide awake and get ready for and help you You want to keep their attention and treat them on the way still. You don't want them to go, you don't want them to go to sleep. Let's see, where's my button? Why? There we go. All right, so spontaneous pneumothorax. All right, so this has to be caused by something. 90% of your spontaneous pneumothoraxes are by a trauma incident. I've seen them a lot in T-bone incidents in cars where they take that quick jolt. I have seen it on a rear end where the seat belt was ultimately the cause of that pneumothorax. But remember what pneumothorax stands for. So y'all remember in the class that I did a horrible job in on breaking down medical terms and all that, that you know what pneumo and thorax is. So you can figure out that's air in the pleural space. It's inside the thoracic cavity. So that being the, oh, look, there's a pretty little picture. So right here, here's our air in the pleural space. Now, there is a hole which is allowing the air to get into the pleural space. Now, air is supposed to be in the lungs, not out of the lungs. And what I try to remind people is it doesn't need to be in this lung cavity inside of our chest wall. But this right here, y'all can turn that light on if I need to. So this right here is the, oh, my cursor, there it is. So y'all can add, this is the chest cavity, and this is what the normal lung's supposed to inflate like. But now that we have the wound, it's going to be recognized and there's going to be air inside that pleural space. So we just got to fix that. All right. So when the surface of the lung is disrupted, air escapes into the pleural cavity and the negative vacuum pressure is lost. That's the definition of it. Okay. So a patient with a spontaneous pneumothorax becomes dyspnea and might complain of a pleuritic chest pain. Like, this is like, it just hurts like right here. I'm having trouble breathing. All right. Breath sounds are absent and decreased on the affected side. So if it's on the right side as well, as you see right there, they're going to have trouble breathing on the right side and have the potential to evolve into a very big life-threatening pneumothorax if not caught early. That's the best thing I can say about pneumothorax. What is pleural effusion? Is a collection of fluid on one side of the lung, compresses the lung and causes dyspnea. So this is basically just fluid inside the lung. Basically what you're going to see right here, these patients are, and I'm underlining that for a reason if I can, my cursor catches up. So what that is you're going to find these patients that don't want to come out of a seated or a 45-degree position. If you put them lower than 45 degrees or flat to their back, they're going to quote unquote drown, okay? Because they feel like the fluid is taking up all the space. And like, I can't breathe, lay it down, I can't do it. And they sit right back up. So that being the case is that lets you know that you're going to have fluid inside the lungs. Now, another sign that you can look for in this timely manner is look for swelling of the legs, the arms. I'm not picking on anybody, but look for the cankles. Those will tell you, oh, well, they're carrying a lot of extra fluid. Not just because the person may be thick, but it could be because they are carrying the fluid. You can do the edema check. You can take a finger, push in on their ankle just a little bit, and that's okay. You don't want to push super hard. And if you can continue to see the impression of your finger, that lets you know that it's a fluid of edema, not just another cause of maybe being thickened from the south. I had to say that quietly. All right, so airway obstruction. Patient with dyspnea may have a mechanical obstruction. And semi-conscious and unconscious patients, the obstruction may be the result of an aspiration, vomit, or foreign object, or improper positioning of the head. Okay, that's a lot. I'm sorry. If the patient was eating just before the onset of dyspnea, always consider possibilities of foreign body obstruction. I'm gonna tell you, every time I've gone to work a code, They always just ate. They've had greens. They're in the bathroom. They've thrown up in the smallest part of the house. It sucks. I don't know how you want to put it that way, but that is just how it is. They don't ever do it and are in a good place. So always remember, no matter what, have your suction handy because you're gonna need it. Y'all give me just 1 second. My wife's asking me a question. I'm gonna pause y'all for a second. All right, sorry, I'm back. So always consider suctioning because you're going to need to suction the airway because that is probably what caused it. I'm not saying that it is, but it's a good sign to go ahead and get ready to suction. And no matter what, again, if they start doing CPR and you have improper head placement, or if the paramedic gets there and they bag and it's into the stomach, into the gastric area, you'll see the stomach swell and it's got to go somewhere. It's going to come up or go out the butt. It's going to poop. And I tell you, that's just nervous. So here's some foreign body obstruction occurs when objects such as food is lodged in the airway, as you can see there. The tongue is blocking the airway on picture B. So if you do the head tilt chin lift, remember when I got everybody to look upward the other night, and you can actually look to the air, that automatically moves the muscles right here, underneath here. This will pull the muscles of the tongue more towards the front of the mouth. Here, they're basically chin to chest, and that is causing the muscles to relax. And they can block the airway. You're not going to swallow your tongue, but the tongue can relax and compromise the airway. So that's what's meant. So a PE is anything in a circulatory system that moves from its point of origin to a distant site and lodges there, obstructing subsequent blood flow in that area. Circulation can be cut off completely or partially. An emboli can be fragments of blood clots and an artery or vein that breaks off and travels through the bloodstream. Foreign bodies such as an air bubble, what happened? Oh, so a PE is a blood clot that circulates through the venous system and the right side of the heart and lodges into the pulmonary arteries. So a PE can also be visually seen. Obviously, yes, if you get them into the right place, they can see it on the robots and all that stuff. But if somebody dies of a PE, you will notice that the patient will be purple, basically from about nipple area up, because that's where that it's blocked. I hate to say that's the only way that you can see it. It is this situation. So that's the worst case, is when they die and you see them that way. 2 seconds real quick. Let me pause this. Obviously, I'm changing slides, so let's go back. Go back. All right, so a PE is something that just it can occur. It can break loose. It can be the clot that travels through the body, and it can partially occlude it. You can notice, like, if it's a partial occlusion or it's a full occlusion, it's in the leg. The patient will complain of a lot of leg pain. They'll have pain in certain areas. Obviously, if it's in the chest or higher, they can have respiratory compromise, cardiac arrest, and last being, unfortunately, is death. Signs and symptoms: dyspnea, tachycardia, tachypnea, various degrees of hypoxia, diagnosis, acute chest pain, and I know what that is. I just can't say it. I don't know. With large enough embolism, complete obstruction of the output of blood from the right side of the heart will result of death. So that being the case, is look for those early signs. Your tachycardia, you may know when you check their heart, or if y'all are able to put them on a cardiac monitor, just as in a pulse ox and blood pressure, and you start to see that they're above 120, that can be a sign. You notice the cyanosis, you have they're pale, you see the blueness in their lips, and stuff like that. Some onsets of acute chest pain, it may hurt now and then hurt then, but they don't have a history of it. That's where your acute chest pain comes from. So hyperventilation, that is defined as an overbreathing to the point that the level of the arterial carbon dioxide falls below normal. So hyper means too much, obviously ventilation. This may be an indicator for a life-threatening illness, and I can promise you that it's going to be. It's going to be an issue. The body may be trying to compensate for acidosis. There's a difference between putting the body in acidosis that you want to if you do keto versus doing it on a regular basis. So if the body doesn't want the end to be keto and to be in acidosis, what they do is they start to hyperventilate the patient to make them breathe further, and they can breathe faster and irregular. So that's how they deal with that. Let's see here. Hyperventilation, again, we talked about alkalosis. This can be caused by symptoms of hyperventilation syndrome. You all know what panic attacks are. We've talked about that. People know in some sorts, at some point in our lives, we've had these symptoms of potential panic attacks, where you have anxiety, dizziness, numbness, tingling of the hands and feet. Tingling of the hands and feet can also be from hypoventilations. They're not breathing enough, they're hypoxic. That can be signs of it too. If they hyperventilate and they start to lose the tingling, like, oh, I can't breathe. Well, the body's just starting to slowly hit an automatic reset. So when they pass out and they wake up again, it's just like hitting the reset button. They're like, oh, I told people before, if you keep on, you're gonna pass out. You'll wake up and breathe normal in a minute. And people are like, how are you not doing nothing? Well, there's nothing I can do. The body's in the process of resetting itself. If it doesn't reset, that's when I have to do something. So, all right. So environmental and industrial exposure. So the biggest thing that we want to talk about here, and I'm not going to harp into this, is like I said, we're all grown folks, but we know carbon monoxide, that is something that we hype on a lot for people to put in the detectors in their homes. It's colorless, odorless, and it's very poisonous. Don't put yourself at risk at any point in time. So like natural gas. So here's an example. You know, natural gas technically doesn't have a smell. The smell of eggs and rotten eggs is what's put in there, so you smell it. It is colorless, it's odorless, it's the same thing as carbon monoxide. They both will kill you, but it's kind of hard to put a smell in something like carbon monoxide when you don't know how it's made in a house. So it's hard that way. So it's easier to just put it in like a natural gas. But the thing is here, again, don't mix chemicals like cleaning solutions. You can create something very, very toxic, like pond salt with bleach. That's very, very bad idea. I do not recommend that. You could potentially cause a lot of harm and kill yourself when you're just trying to clean the commode or the tub. So be very cautious on that. Don't mix chemicals. So when you size up the scene, this is going to, what I want you to do is make sure that you know what you're responding to. And that way that you say, if you know you're responding to an industrial plant, that means you know how to respond. Do I need to stage and wait for hazmat to arrive to bring the patient to me? You always want to wear at a minimum eye protection and gloves. Anytime you go into a scene, that's what you always want to have on. If it, even though we know that 911 was activated, but why? I want to know why was I called out here? Not just because Fred was not feeling well, but Fred says he's always feels bad. But so why did it make you call him this time? You know, question the bystanders. You have to build a scene and a picture of everything that's going on, because remember, we only see these people in their bad times. They don't invite us to these company picnics, or the family on the corner is having a bowl and they didn't invite us to that crawfish bowl. They only brought us there because Fred can't boil crawfish right, and dumped them all in and burned himself. That's what we get called for, and then we don't even get the crawfish. So what I want you to do is always identify the immediate life threats. If you know that the person lost its arm and you need to put a tourniquet on, that has to be done first. I can worry about the breathing and all that later. I have to fix the issue at hand. If the patient is not breathing, that is a life-threatening assessment. You fix the breathing, and then you go to everything else. We talked about before the AFPU scale. Know what your alert, verbal, painful, and unresponsive. Know how to judge somebody and know how to rate them when you get there to assess them. Ask the patient, what's going on? I'm having trouble breathing. Okay, tell me about your trouble breathing. I need to understand what you're dealing with. And they're going to look at you and be like, what? Like, you really give a crap? Because nobody else did. That's the only way we can treat them. Know what's going on with them so we can move forward and make things better. That's the only thing that you can do it. So if they give you a list, write some information down and be like, okay, Mr. Fred, I want to address all your issues, but I want to address the most important one right this second. So which one is bothering you the worst? Now, when you ask somebody to rate their pain scale on a 1 to 10, 10 being the worst, don't just tell them. Women, it's easier to y'all to take pain scales as men, because you can say, hey, 10's of childbirth. Which one, how high is this? And they're like 2. Your arm's missing. It's still a 2 compared to delivering a baby. Men, I'd say we're a little bit more babies than they are. The worst thing we can say is passing a kidney stone. Maybe that's 100. I don't know. But address their pain scales associated to what they tell you. And it may not indicate, saying, oh, okay, well, your protocol say if there's pain scales of 7 or higher, it requires ALS intervention for pain medication. Well, what if Fred stumped his toe and they broke his toe and he just wants to go to the hospital and seen faster? And if they know the system, they know if you give narcotics, you have to be seen faster than the other ones. So that's part of it. Airway, breathing, and circulation. Always assess the rate, rhythm, and quality. That's the only way you'll know about your patient. And is air going in, is air going out? Well, that's important because as you're assessing this patient, you want to breathe too. So that's the biggie. And does the chest rise and fall with each breath? Now, and we want full contraction and full relaxation of the chest each time. Is it, well, that's not going to be good enough. I'm going to have to do something to fix that. And at the very bottom, you see where it says, is the rate adequate for the victim's age? Well, I thought they were patients no, I'm just kidding. So I just need to know, is their vital sign in range with their age group? That's really, I need you to know that. So here's some places, if y'all will look at here, how you assess the respiratory rate. This is where you lay your stethoscope for auscultation. You're trying to listen to the different lobes of the lung, upper lobes and lower lobes. So that right there gives you the, I've always called 8 places of auscultation, 4 on the front, 4 on the back, but obviously there's 10. So, and you want to assess for any of the wheezing, rales, rhonchi, or stridor. And note that, where did you hear that at? Well, I heard it on the left upper and left back lobes of the lungs. Okay, cool. Then now that's accessible that we can turn around and tell the medical facility to check that further. Circulation. Do they have it? Do they have a pulse? Do they have right rhythm, rate, and quality? What is their pulse? And that's a good time for you to check it. Is things functioning properly? Do I have them? What are they perfusing? What is their color, their skin, temperature, and condition? I don't want you to know. I don't want you to put on there that they flaky or they got some pale, moist skin. Pale is fine, moist is fine, but don't put they flaky. That's I've seen that in a report. It didn't go too far. They got in trouble for that. Transportation decisions. Again, you're gonna know what you want to do with your patient as soon as you get there. Be like, wow, this looks like a really bad wreck. I want to go ahead and make the decision. Let's make this a turn and burn. Once you get to your patient's side and you realize, oh, this is not as bad as I thought it was, it's okay for you to tell your partner, hey, we're gonna call for more units, but we're gonna stay and let them transport. So if that makes sense, that you need to know that you get a game plan, build your game plan with what's going on, and then move forward. It's okay to change it and it's okay to upgrade, but make sure that you're making those right decisions. Address life-threatening, proceed with rapid transports, what we talked about. We know those, and go to the most appropriate facility. If it's not the right one, it's not going to help the patient. If you're just taking them to the quick Band-Aid station with no doctor, they just have some nurse practice, they ain't going to be helpful. You're going to look like a turd because you didn't do what's best for your patient. Okay, so I'm going to cover these last two and we're going to take a break. So in history taking, this is when you get to become an investigator. I want to know who, what, when, where, and why about this patient's complaint. A patient with respiratory distress, a sample history can be collected from bystanders or family if they are present. If they're not able to tell you what's going on, you just got to ask the patient. You're just going to have to ask and do the best you can for documentation. If the patient is a respiratory failure and they can't breathe or they're unresponsive, you just got to go with what you see. Just be like, 40-year-old white male found on the ground unresponsive. CPR began at such and such time. Transport decision, we transported to such and such hospital at this time. And then now you're going to have to list all the stuff you did around the facility, but you don't have time to be that investigator. You don't even know what 40-year-old white male's name is. You don't really care. We'll find that out later. We talked about your OPQ-RST because I remember y'all talking about that and writing it in the chat. The PACE assessment is an alternative assessment for a complaint of shortness of breath. I don't use this one much. I don't know much about it, but it talks about progression, associated chest pain. Is there any sputum? Talking tiredness, and what that means is, are they talking and are they tired when they talk? And exercise tolerance. Are they able to get up and move? When they get up and move, how are they? How do they respond? So that's your PACE. I like OPQ-RST. I will always use OPQ-RST because that's what I know and that's what I was taught. So that's the best I can tell you. All right, folks, I'm going to take 10 minutes and I'm going to try to scarf some food down and we'll be back. We don't have that much longer, so don't get super tired of me. We probably have, I don't know, less than 25 slides. So see y'all in about 10 minutes and we'll get going again. right, folks, let's get back to this. Get y'all done for the evening, on to your family duties. All right, so your secondary assessment, this is going to be more detailed. I want you to do OPQRST, DCAP BTLS. Have I gone over what DCAP BTLS stands for yet?
Yes.
Okay, I just want to make sure. All right, so we're going to do that to every single extremity. We're going to do it to the stomach, then we're going to do it to the abdomen. No, it's the same thing, but you're going to assess it twice. Then you're going to do it to the chest, the head, the neck, the face. Each part of it is going to get a DCAT. Now, again, this is going to be slow, more methodical, more detailed, and you're going to be asking for responses at the same time. Now, granted, hopefully the patient can respond to you. If not, what you're going to be doing is you're going to note any changes. You're going to note any issues in the area. You're going to say, hey, I found a deformity to the right upper right arm. I found a burn or bruising to the left lower arm. All that's going to be noted into your secondary assessment. When we go for talks about here secondary assessments going into COPD, they are usually older than 50 years of age. Doesn't mean that it won't happen younger. They have a history of lung problems and probably have been an active or former smoker. They will complain of tightness in the chest and constant being tired. Well, y'all tell me why you would think that they're constantly tired. What do you think causes that as a COPD patient?
They need more oxygen.
Yeah. Lack of oxygen will cause that. It's because your hypoxic drive is just, it's like you've kicked it in the butt. They tired, bro. They always tired. Like, coach, don't put me in, man. I'm done. They constantly they're just wore out. So they have a barrel-like appearance to the chest. You'll notice that it's bowed out. I can't tell you why, but that is more common. I want to go more towards just the elastic of the chest has been pushed out because it's trying to open up more area to get more oxygen in, but I can't really tell you that. Now, if you'll look at the, so here's another one that'll tell you, and I like to point this out because I'm very observant to people, is they have distal clubbing. So their fingers will be abnormally enlargement of the ends of the fingers. So it looks, so right around their fingertips and their fingernails will be, they look kind of like a golf club, like a driver. They're just abnormally large. I went to a school with a girl that had that, and she was COPD, but she was born with lung problems, and that's the way she was born. She unfortunately recently passed away, but it's because their body's striving for oxygen, and it's just, some people may not tell you they're COPD, but look at the fingers. I've seen that in every single patient that I've taken care of in COPD, that they have the clubbing. Sometimes you will see it in your older smokers because of the body. It's done. It needs that oxygen drive that's just not there. So your reassessment. Anytime there is an intervention, if you provide oxygen via the mask, 15 liters a minute to a non-rebreather, document it. Because you're providing positive ventilations using a bag valve mask, a pocket mask, flow restriction, oxygen power device, it doesn't matter. You need to document that. Did it work? Did it change anything? Or no matter what you did, has it improved it? Have they become worsened? If you have to change from giving positive pressure to you have to bag this particular patient, and you're putting them in a head tilt chin lift, and you put in a OPA or an NPA, Those have to be documented. If you get down to the point to where you're assisting with respiratory medications, maybe you're riding in with a paramedic, they may ask you to note times. If you're given a medication at this time and they're extremely busy, documenting that is a good way to just write it down for them, stick it on something, but just make note of time and route. Those are big helpful parts. Just helping with the documentation, because after you work a really bad incident, it gets combobulated. It's a lot of crap to keep up with. Emergency care. So administering of supplemental oxygen, administer ventilatory support if the patient's mental status is decaying, declining, not decaying. If they are in moderate to severe respiratory stress, or if the depth of respirations is inadequate, you provide oxygen. Monitor the patient's respiratory status. How is it? Is it good? Is it bad? Now, don't just put like he looks like crap on your report, but just be honest. Patients stated they felt like they were going to die. Be that you have to provide that emotional support during this time. Yes, sir, I understand that you feel like that you can't breathe. I'm doing everything that I can for you at this time. If the patient may have a metered dose inhaler or a small volume of nebulizer, give it to them. Don't withhold that. If you have to consult through med control, make that phone call early. Respiratory complaints and failures will catch up with you in the worst time and make you look bad because you didn't do nothing. So be cautious of that. Jump on that early. Ensure that there are no contraindications to the patient's conditions. So that being said, is depending on the medication that you're trying to give, what's it gonna do to them? Most respiratory inhalation medicines are used to relax the muscles that surround the air passage to the lungs, leading to dilation of the airways. So what I'm trying to do is I'm not allowing more oxygen to go in there. But some of the other things that you're going to see, some contraindications, you'll have an increased pulse rate. They may get a little nervous, but they may have some muscle tremors. So if they hit that nebulizer a couple of times, back to back to back, that could create your muscle tremors or your nervousness. I've seen the pulse rate go up, but because it's the respiratory drive kicking in. Medication from an inhaler is delivered through the respiratory tract to the lungs. So remember that you may have to provide some oxygen to help speed that process up. If you look in your book, 16.1, you have how to help a patient administer a meter dose inhaler. And 16.2 on your book is medication, how to help a self-administered of a small dose nebulizer. Oh, what's that one say? Administer humidified oxygen. Do not attempt suction airway in place of. So the biggest ones I want to point here is position them in a position of comfort, right down here, and position and transport promptly. Don't stick around. Don't delay it. If it's time to go, go. Don't wait around. Get going. If the patient, if you think they have a epileptitis, don't putting in a oral airway is going to be a hard time doing that, because the patient will fight you. They will because it's raw, it's uncomfortable, it's tight, it's small. So be cautious of that. Pay attention to what your assessment shows, your investigation. If they have a history of epileptitis, guess what? Probably got it again. So pay attention to that. Acute pulmonary edema. The best thing we can do on that is just give them oxygen and transport them. Suction, if they need it, you can show them how to do it. You can turn it on, and you can do other things while they do that. Again, I like to put people in about a 45-ish degree position. That is kind of like the relaxation in a recliner position. that kind of helps with your transport. If you're able to, depending upon what your protocols allow, put them on CPAP. CPAP's not that bad. It's not hard to get used to using. It forcefully opens those bronchioli and alveoli to allow oxygen in there. And that's just sometimes what the patient needs is more oxygen. No, I don't need CPAP right now. Y'all don't think that for me. And transport promptly. Don't delay because they're going to go to respiratory failure without the appropriate care. COPD, assist with prescribed inhaler if they have them. Note what time you gave it. Note that the patient took it on this time. This was the dosage. Write all that down. 2 and 3 we just talked about. I don't see the point going over that again. Asthmas, transport if required. Sometimes people can get those under control and they call you because they get worried out. But be ready to provide aggressive airway control. If you have to do that and drop that OPA or NPA and they don't have a gag reflex, that's fine. Just drop it early. You can bag them. Get ready for that. If they go into anaphylaxis, if they have their epi on them, get ready for that. If they need to give it and give it early. Note the time it was given by the patient and proceed on with your care. Hay fever, we've all done with that. Most of the time, people don't need transportation to the medical facility with hay fever. I have seen some crappy EMS runs before. It's really difficult to tell somebody that you can't take them to the medical facility, that they don't need a ride in an ambulance. Maybe they need a ride in Uber. Some agencies may allow you to do that. Some may not. So be very cautious on that. If you notice them to go into anaphylaxis and you need to remove them from an area, let's say that there's peanuts and they have allergic to peanuts. Be cautious when you go to remove them that you're not moving them into your ambulance where you just got finished eating peanuts. So, but if you have to remove them or they're being stung and that's what caused it, get them out of the area as fast as you can and safely to yourself. Pneumothorax, the best thing that you can do is transport, recognize what it is and monitor it. Let the facility know. I would definitely call for ALS intervention so that they can intercept you and provide some ALS care on the way into the facility. So pleural effusion, the only thing you can do there is transport, provide some oxygen. If there's shortness of breath, treat your patients and just transport them to the facility. There's really nothing that you can do, nor I myself can do out in the field. They just need that pleural effusion removed. That's you just got to take the fluid off. Got to go mile somewhere, and they got to pull it off. Treatments, specific conditions. We talked about airway, partial obstructions, full obstructions, how to put them maybe in position of comfort. I mean, a head tilt chin lift, providing that you clear the airway. You may have to do a Heimlich maneuver. You may have to do an abdominal thrust if they've already passed out. You can use a finger sweep, but don't put your fingers in their hands, in your mouth. We have tools for that. Like if you see something in their mouth and you can roll them to their side, you can use a finger sweep as long as you stay in their cheeks. I just want to make sure we add that. Y'all probably learned that through your CPR. But transport rapidly, best thing you can do because you're not going to be able to put an OPA down. You may put a bit of an MPA because it's going in the nose. Pulmonary embolism, be careful moving them. Obviously, it moves through the blood flow. So get them in a position and transport very carefully. You still want to transport them rapidly, but if you know that there's an active PE, moving them rigorously or down a very bumpy road may not be the best thing for them because that can potentially move and kill them. So smooth, comfortable patient care, transportation to the facility is what this patient needs. We don't need any rapid transport that can cause that PE to move places, because it's going to just be detrimental to that patient. Hyperventilation, just the best thing you can do is reassure your patient and provide supplemental oxygen, because over time, we know that that's going to stop. The patient has to get their oxygen levels to the high enough that they can calm down, and then their drive just, it could happen to where they just need to pass out and everything resets. That we can go that far. But don't just be like, oh, well, you know, we'll just wait and they'll pass out and everything will start. Well, that, yes, but that does look bad on you if you don't do nothing. You can explain some things as long as you know what you're talking about and some more details. That you can say, hey, listen, if you don't pass out, your fingers are going to start cramping. They're going to start pulling in, and then you're going to complain that you're going to freak out worse, and then you're just going to pass out. But once you do wake up, I'm going to be sitting right here smiling and say, I told you. So things like that. Environmental industrial exposures, exposures. Make sure your patient is decontaminated before you put them in the ambulance. Do not put a contaminated patient in your ambulance, and then you potentially have contaminated you, yourself, and your partner, along with contaminating the ER, because it's an unknown. If you go to a plant explosion or there was a possible exposure, make that patient change clothes and or wash them. I don't mean like with the loofah, but you want to wash them with copious amounts of water by the fire department. They can do that. Foreign body aspirations, clear it the best way that you can. Provide oxygen and transport as fast as you can. Trachostomy dysfunction, there's just really not a whole lot you can do for that, besides trying to suction it and giving them high flow O2. You know, most of the time, so your agency may have a tracheostomy mask that you can put over there and put supplemental oxygen through there. Some agencies don't. You just use a regular non-rebreather and hold over the trach. But that's, again, that's gross. They really gross if it's not maintained well. New ones are just gross too because they got to change colors. Oh, that's gross. Sorry, I had to change topic. Asthma, you don't want to give them straight nasal like a non-rebreather, because they can potentially freak out that it's there on their face. They feel like they're smothered, and that creates any more issues. So just a blow by will work there. Cystic fibrosis, that is a genetic disorder. Predisposed children to replace lung infections. Some symptoms range from sinus congestion to wheezing and asthma-like complaints. You may need to just suction and oxygenate as needed, and just ask them, hey, listen, I'm sitting right here. If you want some oxygen, please let me know. I am monitoring your vitals along with your oxygen saturation. So if I do see that your oxygen drops a little low, I may already put it on. But if you feel like you need it during the transport, just please let me know. And that's kind of the overview of some of your treatments for specific conditions. Does anybody have any major questions tonight? Y'all want to recap on anything? Y'all want to talk about anything else? Again, that's it for the evening. Thursday night is a little long, so y'all be prepared to hang out for a little while on Thursday. Any questions, concerns, or want to go over anything else? Thumbs up. I got it. All right, folks. I'm gonna take silence is the key. All right. So listen, there's your class code for the night. It is 9. The @ symbol, money sign, number 1. Don't ask me where I came these up. These are all randomized numbers and stuff. So y'all please jot that down. Do your attendance code, and y'all let me know if y'all need anything. Your test should unlock. I will go through there when we get done here to make sure the times and all that stuff is situated. y'all want to do it tonight. I think I adjusted that correctly. But anybody else, y'all reach out to me if y'all need me, and I will mute it and sit here if y'all need anything else. But other than that, y'all have a fantastic night. And don't forget, tomorrow's my birthday, so I'll be waiting for the gifts. Y'all have a good night. Bye, y'all.
Appreciate it. You too.
Happy birthday, brother. Have a good day tomorrow.
Appreciate it. You too. See you later.